everybody. My name is Astrid Indrafebrina Sugianto. I'm a medical doctor and currently a general surgery resident at the University of Indonesia. Uh, I'm from Jakarta, Indonesia, and I would like to present my research with the title of Clinicopathologic Predictors of Therapy Response in Intermediate to High-Risk Thyroid Carcinoma after total thyroidectomy and radioiodine ablation. Well, we'll start off with the introduction. So, for everyone here who hasn't been very familiar with thyroid carcinoma is basically um, a cancer that occur in in our thyroid gland. It is one of the most common endocrine malignancies, and the incidence continues to increase globally. In Indonesia itself, thyroid cancer accounts for 10.2% of all cancer cases. And the most prevalent histologic subtype is the papillary thyroid carcinoma, which is the most common type. The primary treatment at the moment is total thyroidectomy. And for patients with intermediate to high risk of recurrency, surgery is often followed by radioiodine ablation. Despite standardized surgical and adjuvant management, therapy response varies among patients. Some achieve excellent response, others develop biochemical or structural incomplete response within a period of time post the surgery. So I haven't explained. So total thyroidectomy is basically surgical removal of our thyroid gland over here. This variability suggests that treatment alone does not fully determine the outcome. That's why the underlying tumor characteristic that may influence therapeutic outcomes is important to be understood. So we are going to see the association of clinical pathologic profile as a potential determinant therapy response. Several parameters that or variables that are going to be observed are includes tumor size, vascular invasion, multifocality, lymph node metastasis, distant metastasis, and histologic subtype. These variables reflect tumor burden and biological aggressiveness of the cancer itself. Understanding this relationship between these factors and the therapy response is very important because it may help predict the prognosis early, which means we can manage the patient's expectations for the therapy or the future to come. It may also guide post-operative surveillance, like how often or how short the interval would be among in between evaluation. And it may also support risk-adapted management strategies. Do we need more dose of the radioiodine ablation, or do we need targeted therapy as a complementary? So the objective of the study is the study aim to evaluate the association between these factors and therapy response in patients with intermediate and high-risk thyroid carcinoma following total thyroidectomy and radioiodine ablation. The study design was a cross-sectional analytical study. We extracted secondary data from medical records of thyroid carcinoma patients between the year of 2020 to 2025 at Cipto Mangunkusumo Hospital in Jakarta. The study population consists of intermediate to high-risk thyroid carcinoma patients fulfilling inclusion and exclusion criteria as mentioned in the slide. So the sample size, minimum sample that was required was 51 patients, and the outcome assessments was based on the classification of therapy response based on American Thyroid Association criteria, which classified into 4 different groups: excellent response, biochemical incomplete response, structural incomplete response, indeterminate response. And then these in this study, we are going to see the association between these clinical pathologic factors and therapy response after the intervention of total thyroidectomy and radioiodine ablation. The data analysis was conducted using SPSS version 26, and we also we evaluate the variables with p-value below 0.25 in bivariate analysis, included in the multivariate logistic regression analysis. The result, the basic characteristics, total eligible patients included in the study was 85 with a mean age of 47.3 years, ranges from 18 to 72 years old, with 74.1% female and 25.9% male. The tumor size distribution varied, but the majority presented with T2 or T2, T3 tumors. T2 is 2 until 4 centimeters in size of the tumor, and T3 is above 4 centimeters in size. The therapy response distribution among 85 patients, where the majority fell in the structural incomplete response group, which is 45.9%, and followed by excellent response group in 40% among 85 subjects. The therapy response and clinical pathological correlation that we observed, there are significant factors associated with worse response. So patients with the worst outcome came with the larger tumor size, with presence of positive extrathyroidal extension, with vascular invasion, with lymph node metastasis and distant metastasis. However, other two parameters or two variables, which are the multivocality and histologic subtype, did not really have any association with the therapy response. The therapy response and clinical pathological correlations was observed, was analyzed using bivariate analysis. So for the subtype, in the papillary thyroid carcinoma, it has many variant of the papillary thyroid carcinoma. That's why, to make it easier for us to see the correlation, we classified it into two major classification, which are the follicular variant and non-follicular variant. Because the follicular variant has highest proportion among the other variant, and there was no significant difference in therapy response with chi-square of p-value 0.968. And then we move on to the multivariate analysis. The variables that included are the variables with p-value below 0.25 in the bivariate analysis, which are the tumor size, extrathyroidal extension, vascular invasion, and metastasis. In this evaluation, we can see that the chi-score was 6.248 and significance was 0.039, which indicates that the model is statistically significant. However, aggressive clinical pathological features collectively contribute to therapy response, although the explanatory power of the model is moderate. And then we also look at the correlation based on the multinomial logistic regression analysis to allow us to see the response therapy divided into 4 different groups. And then we can see that the significant predictors of poor therapy response consist of tumor size T4, which is there is extension outside of the capsular tissue, which is bigger than 4 centimeters. And then with the presence of extrathyroidal extension, and then metastasis of the lymph node. The result was borderline for distant metastasis and not significant for tumor size, T2 up to T3, which are our majority of the which is the majority of the subject, vascular invasion, multivocality, and histopathological subtype. One thing to note from this research is that post-thyroidectomy service timeline in the hospital varied widely. Thus, the follow-up shows wide variability in timing, reflecting differences in clinical practice, patient conditions, and follow-up readiness. Thus, it might affect how the therapy response resulted in. And then, so what we want to see, which factors really matter in the result, in the outcome of the study. The first one to look at is the tumor size with p-value 0.019, which says that the large tumors has higher proportion of structural incomplete response. Because when the tumor size is large, there is a greater capsular penetration, which results in higher residual tumor burden, which there might be residue post-surgery. So there is also less homogeneous radioiodine distribution, which in the pathophysiological aspect of it, the large tumors tend to penetrate the thyroid capsule and surrounding tissue more aggressively, causing more heterogeneous radioiodine distribution that reduces the ablation success. And then the second variable is the extracellular extension with strong association with structural incomplete response, 59.4%, which indicates there is a capsular infection that causes the complete resection to be difficult to achieve during the surgery. It has also high risk of microscopic residual disease. And in the previous study, ETE is known as an indicator of aggressiveness of the cancer. It indicates capsular infection and infiltration of surrounding tissue. It complicates complete prosection, as mentioned before, and it is highly associated with long-term recurrence risk in the next 5 to 10 years, especially when there is presence of lymph node metastasis. The next one is the vascular infection. It has significant correlation with p-value of 0.02. When there is a vascular infection presence, it enables hematogenous spread. So it supports the tumor cell emboli mechanism, in which case the cancer cell circulate in the circulation. It goes to the circulation that increases the micrometastasis risk. The next one is the lymph node metastasis. It has the strongest association with a p-value of 0.005 with structural incomplete response proportion 62.5%, where the cancer has spread through the lymphatic pathways, where the lymph nodes can act as a sites of residual diseases. So even though the thyroid gland has been surgically removed, but the cancer cells remain circulating in the lymphatic pathways, causing it to metastasis. And then the next one is the distant metastasis. It has a very high proportion of structural incomplete response, in which there is cancer left in the body even after the surgery, which is the 85.7%. That indicates that the patient has been in an advanced stage disease at the beginning of the diagnosis. It is associated with tumor dedifferentiation, in which case the cells they differentiate into more pluripotent or more precursor cells or more immature cells that lose the ability to transport sodium iodide, in which case it reduces the ability to uptake radioiodine during radioiodine therapy. It results in lower effectiveness of the therapy. In these cases, targeted therapy can be an option. However, it should be discussed furthermore with the patient as well. And then the next one is the multifocality and histological subtype. As mentioned below, before in the result, there was no statistical significance. In the multivariate analysis and clinical implication, when adjusted together, the tumor size, the ETE, the vascular infection, and the metastasis, there was no independent statistical significance. However, ETE and lymph node metastasis showed independent association, but it has low pseudo R-squared values, in which case, which suggests that these variables explain only a small proportion of outcome variability, which means that there are certain factors that are outside the model has bigger impact size. And then as an interpret that's why this data need to be interpreted carefully. The clinical pathological factors overlap and interact. Colleaguely reduces independent effects, and tumor aggressiveness is multivectorial. It can be affected by other variables that are not included in the study or in the model. This supports the importance of, first of all, the dynamic risk stratification as mentioned by American Thyroid Association 2015 guideline, and continuous risk stratification based on the initial response and follow-up findings. In the ATA 2015, the evaluation or dynamic risk stratification can be conducted at any given time, as long as the patient can be evaluated through thyroglobulin level or the ultrasound results. So we have to continue risk stratification every time we see the patient. So evaluation cannot only there is no time bracket given for the reevaluation. Reevaluation should be done repetitively. And then as a conclusion, there are several clinical pathological factors such as the tumor size, extracellular extension, vascular invasion, lymph node metastasis, and distant metastasis that are significantly associated with therapy response on bivariate analysis. However, multivariate analysis does not identify a consistent independent predictor, likely due to, sorry. Oh, there's an error. Okay. Likely due to Okay. However, multivariate analysis does not identify a consistent independent predictor, likely due to overlapping and interacting effects among aggressive tumor features. Therefore, baseline pathology alone is insufficient to determine long-term outcomes. As a take-home message, management of differentiated thyroid carcinoma should rely on dynamic reset stratification that are done over time, integrating initial clinical pathological features, response to therapy, and ongoing follow-up evaluation. Thank you very much for your attention.